Our next speaker, Lynn Henry, is a medical oncologist at the University of Michigan, where she continues to treat patients with breast cancer for more than 8 years. Her research is focused on predicting who will develop toxicity from breast cancer therapies, especially anti-hormonal therapies. She also investigates why certain patients develop side effects and how the symptoms can either be prevented or managed. She has published many articles investigating the musculoskeletal side effects that commonly occur with aromatase inhibitor therapy. She is currently the study chair for SWOG Study S1202, a randomized placebo-controlled phase 3 trial of duloxetine for aromatase inhibitor-associated musculoskeletal pain. Please welcome Dr. Henry.
Thank you very much. And it's a pleasure to be able to talk with everyone today. Is this sounding okay to everybody you can hear in the back? So I'm one of the medical oncologists at the University of Michigan. I've been there for fellowship and then I stayed on as faculty. And really the entire time, my primary goal with my research program has been to try to understand how we can make the lives of our breast cancer survivors better. You know, they go through so much after they're diagnosed, and then some of them have to have chemotherapy and radiation and surgery. And then for a large subset, we end up putting them on medication for 5, now 10 years. And they really, you know, some women can be really, really affected by these medications. And what can we do to make their lives better, both so that they can just feel better, but also so that they can continue to take the medications without taking a significant negative hit in their quality of life, and that they're not tempted to stop the medicines, which then may compromise their ability to be cured from their breast cancer. So that's really where I'm coming from for talking with you today. The one thing I do need to say in terms of disclosures is I do have some disclosures in terms of research funding, which are not relevant for this at Celldex and BioMarin. But also, I will be talking about an off-label use of an FDA-approved product. So, as I sort of just alluded to, in terms of the importance of endocrine therapy toxicity, you know, we start out with women on endocrine therapy, and then we have high rates of poor adherence and persistence. So a lot of people either don't adhere, which means they take the medicine, but they might take it only every other day, or might take it half a dose. They don't take it the way that their doctor prescribed it to them because of, you know, for various reasons. And then also some people are non-persistent with their medications, meaning they just decide to stop completely. So they actually finish early. And doing this has been shown in a number of clinical studies to lead to increased mortality from breast cancer. Now, there's a lot of different reasons why people are poorly adherent and persistent. You know, there's reasons such as they can't get to the pharmacy, they can't get the bottle open, they can't afford the medicine to get the bottle in the first place. But really, the large bulk of the reasons why people are poorly adherent and persistent is because of side effects. And so that's what I'm going to focus on in conjunction with the speakers who are coming after me. So just going to briefly mention tamoxifen and aromatase inhibitors. Tamoxifen causes vasomotor symptoms, hot flashes, also gynecologic complications. There's obviously the annoying ones like vaginal discharge, vaginal dryness, but there's also the rare but serious risks of uterus cancer. And then there's venous thromboembolic disorders, which also are obviously very serious, but luckily rare in terms of both deep vein thrombosis and also pulmonary embolism. It works by a completely different mechanism for the aromatase inhibitors. So the aromatase inhibitors, they work by lowering your estrogen level, whereas tamoxifen works by blocking your estrogen receptor. And because the aromatase inhibitors work by a different mechanism, they have a different profile of side effects. And so one of the main ones that people report are these aromatase inhibitor-associated musculoskeletal symptoms that I'll talk about a little bit more in a minute. There's also vasomotor symptoms, so hot flashes, and similar to tamoxifen. There's a lot of vaginal dryness. Of course, this is a postmenopausal population, which already has a lot of vaginal dryness, and we make that worse. Decreased libido, and then finally bone loss and increased risk of fracture. So it is a different set of side effects, but it doesn't have the serious ones that we usually think of, like deep vein thrombosis, PE, and uterus cancer, but it does have some very significant toxicities that impact patients' lives. So when you try to look to see how often are people actually reporting these arthralgias, you know, we have data from all these clinical trials All the ones on the left are treatment trials, so it was for patients who actually had been diagnosed with breast cancer. The ones on the right are chemoprevention trials, so these were trials comparing women who were at high risk for developing breast cancer but who had not actually developed breast cancer. And what they did was all the yellow bars are tamoxifen, all the blue bars are aromatase inhibitor, and then the green bars are placebo. And so the incidence of arthralgia is on the y-axis. And what you can see is it's really all over the place. You can see that in some studies there's as low as 20% report. In some other studies it's more than 50%. When you look at community studies, so not clinical trials, not physician-reported data, but when you actually ask the patients what's going on, it's much closer to the at least 50% range. And when you talk to people in clinic, people say, you know, I used to feel okay, and now I wake up and I feel like I'm 80 or I feel like I'm 100. And a lot of people, once they get going during the day, they feel okay. Some people don't. They continue to be stiff. Every time they sit in the car and they try to get out, they can't get up. They're sitting at work, having a hard time getting up. So we know this is impacting people, even though it wasn't actually reflected in some of these clinical studies. The only other thing that we know is that even though we think of aromatase inhibitors cause all these aches and pains, tamoxifen does too. It is increased compared to in aromatase inhibitors compared to tamoxifen, but there's still a fairly high proportion of women complaining of this on tamoxifen too. So it's not exclusively the aromatase inhibitors that cause this problem, but primarily. So when you're thinking about these, we call them AIMSS, there isn't really a specific definition. There's nothing pathognomonic that you can say, okay, you're examining the woman, she has it, she doesn't. That makes doing clinical trials very difficult. There's a wide variety of common symptoms that people report. Most of it is arthralgias and stiffness. Some people have tendinitis. Some people have muscle aches, much more than joint aches. There is an increased risk of carpal tunnel syndrome. That was shown in 2 of the large clinical trials. There's a lot of other sort of tendinopathies as well. When you ask people, people will report wrist tendinitis, Achilles tendinitis. I'm not sure about plantar fasciitis, but these things are associated. And so a lot of women will seek care from their primary care provider because they will assume it's not related to the drug, when in fact it might be. But the other important thing is this is non-inflammatory. So, you know, if you examine a woman and she says, oh yeah, my wrist is killing me ever since I started taking this medicine, you're going to look at it and it looks perfectly fine. But that is really what's classic for this. We don't see things that you might think of associated with synovitis or with gout. You know, you don't see the inflammatory picture. Often it is in the distal extremities, so it is much more in the wrists, hands, ankles, feet, knees, more so than in the back. And a lot of people complain of moderate to severe symptoms. So this isn't just something, oh, they feel a little bit more achy than they did before. There's been a lot of cross-sectional studies done trying to look at this, and they're all pretty consistent. So one of the big things that I would love to know, and also what our speaker is going to talk about a little bit later, is why do these things actually happen? The big leading reason is estrogen depletion. Obviously, the aromatase inhibitors act by lowering your estrogen levels. You know, postmenopausal women have low estrogen levels to start with, and then we decrease it by about 10-fold. But none of the studies have been able to demonstrate whether or not estrogen depletion is actually the reason. And part of that may be because our estrogen assays are terrible. So if you actually check a regular run-of-the-mill estrogen assay in a patient in clinic, you're going to probably find that she's less than the lower limit of normal, but that's also true before she started the medication. So we can't compare before and after because the assays just aren't that good. And even when you start to use the very super ultra-sensitive assays, they're still not great. The vast majority of people are suppressed the whole time. So it's actually a very difficult question to ask. There's a question about localized estrogen depletion. Is it localized in the bone and the joint and the muscle because we have estrogen receptors there? And aromatase is there as well. You know, is that where it's actually going on? When we do X-rays on people, we don't see structural systemic changes. It's not like you're seeing arthritis changes in the bone. And so the question is there something going on that is transient as long as you're taking the medication? The other question, which is directly related to duloxetine, is that there's a lot of estrogen and also aromatase in the brain and in the spinal column. And is the estrogen lowering by the aromatase inhibitors, is that actually causing people to perceive pain differently. So rather than actually causing pain, are people just feeling like their pain's a little bit different? We've actually done work trying to look at that and have not found anything, but we continue to have studies ongoing looking at that. There's also questions about inflammation, but again, we don't see elevated levels of ANA or rheumatoid factor or other markers in the blood on a consistent basis. And then the same thing with autoimmune. So really, we still don't know. If we knew why these things happen, it might be easier to treat them. And so we continue to sort of work on both fronts, trying to figure out the mechanism for why these things happen. But meanwhile, while we do that, we've been unsuccessful, we still need to treat the women who are having the symptoms on the drugs. So the treatment options that we have, we can switch from one drug to another. So there are 3 different aromatase inhibitors. There's also tamoxifen. So if you start off someone on an anastrozole, she doesn't tolerate it very well, there's always the option to try switching to a different one. Even though they all work exactly the same mechanism and they all have the same side effect profile, we clearly can see that some women tolerate some and don't tolerate another. And so we don't know why. We don't know if it's differences in how the people's bodies metabolize the drug. We don't know if it's differences in off-target effects. We don't know if now the mindset's a little bit different. Oh, I've used up one of my options and I only have a few left. Maybe I should stick it out a little bit longer. But those are options, and also tamoxifen is a perfectly good drug. There's medications that have been tested. Some of these have been tested through SWOG. There's the group here from Kansas has looked at high-dose vitamin D, and clearly those patients who are vitamin D deficient have more trouble with side effects, but the jury's a little bit out on whether high-dose vitamin D is helpful, but of course now we're supplementing everyone with vitamin D to get their levels up, so it's going to be hard to study that one. Omega-3 fatty acids was the SWOG study run by Don Hirschman that was presented at ASCO last year and showed that about 50–60% of the patients who took the omega-3 fatty acids had an improvement in their symptoms, which is great, but so did the placebo. And so now we're trying to figure out what's in the placebo or what placebo effect had. They have been able to look to see that the lipid levels, the cholesterol levels that you would expect to improve with high omega-3 fatty acids improved in the treatment group and not in the placebo group. So we know it wasn't that everyone ran out to the drugstore and bought omega-3 fatty acids. But they're still they have a lot of blood stored, and I think they're trying to look at that. And then there's clinical trials, like the one that I'm going to talk about today. There's also an acupuncture trial going on, also run by Don Hirschman. And then, there's the acupuncture trial. So then there's non-pharmacologic options. One is acupuncture. There's some preliminary, actually single institution phase 3 data suggesting that acupuncture is helpful. So Don has started this SWOG 1200 to try to look at whether acupuncture is effective in a multi-center trial. And then also exercise. And so there's the HOPE trial was presented a couple of years ago that showed if you do a lot of exercise, meaning a lot of aerobic and strength training exercise, you can improve how you feel, you can improve your pain scores. But it's going to be kind of hard to implement in the real world. It's a huge time donation that patients have to make to be able to continue to do the exercise. And while we all agree that exercise is paramount for helping treat cancer, prevent cancer, and also help prevent all those other diseases like heart disease and diabetes, despite that in our busy lives, it's really hard to get that much exercise done. And so although that is a laudable thing and it's certainly something we should be offering and encouraging in all of our patients, it'd be nice. It doesn't help everybody, and also it can be a little bit hard to do. So I'm going to spend the rest of the time talking about the clinical trial. This is SWOG 1202. It's a study that's looking at duloxetine. So many people have seen the ads for the brand name version of duloxetine, which is Cymbalta, which is one of those ads that you watch on TV, and it's 30 seconds long, and the first 10 seconds tell you how wonderful it is to take the drug, and then the other 20 seconds, or maybe longer, tells you about all the awful side effects you're going to have from the medicine. And so this is one of the things that this trial is facing, trying to encourage people to at least try to take the medicine to see if they tolerate it. Yes, the medicine has a lot of side effects, I'll talk about that, but some people actually do great, and a lot of people who take it and tolerate it actually find that it improves their symptoms in our pilot study. And so that's why we brought it forward to this randomized trial. So this is a serotonin norepinephrine reuptake inhibitor. It's called an SNRI. So it's somewhat similar to venlafaxine, and it's different from citalopram and fluoxetine and paroxetine and all the SSRIs. It is a little bit different, though, from venlafaxine in that it's more on the norepinephrine end of the spectrum, whereas venlafaxine is more on the serotonin end of the spectrum. And as such, it does have some different properties. It is FDA approved for depression and anxiety, as expected, but it also has multiple FDA approvals for pain conditions. So it's FDA approved for treatment of fibromyalgia, as well as low back pain and knee osteoarthritis, and diabetic peripheral neuropathic pain. So there's actually a lot of good data out there that suggests that duloxetine is effective in pain conditions, completely separate actually from its antidepressive properties. So that's something very important. It's not that we're just trying to give someone an antidepressant, make them feel better, and hopefully their pain will get better. We actually think there's a separate effect on pain that this drug has. Another drug in that class, something called milnacipran, is also an SNRI, and it has very similar properties. So as I said, it's been studied for diabetic peripheral neuropathic pain. And the other thing is about 2 years ago or so, it was reported for chemotherapy-induced peripheral neuropathy. Now, it seemed to be somewhat helpful. And you can see in the graph here where there was a decrease in the pain. In the black bars, the black dots is duloxetine, and the open circles are placebo. And so placebo was fairly flat, whereas duloxetine did have a decrease. And it's believed to alter central pain processing. This has been studied in diabetes in a small study. And we're actually studying in the University of Michigan to see if that's how it works in cancer patients. But the thought is that it's actually going in and modulating different things in the brain and altering how people perceive pain. We had a pilot study of about 29 patients who received duloxetine, single arm, off-label, single open label study. And so average pain was about 5. You can see that the levels decreased quickly and substantially. It decreased from about 5 down to about 2.5. And it stayed fairly stable for the entire 8-week duration of the study. So this was very promising to us. Now, across the bottom, you can see the number of patients we had enrolled in the study. And so at 0 weeks, we had 29 patients. At 2 weeks, we had 25 patients. So we had 4 people drop out. But then it stayed fairly stable the rest of the time. And that has been our experience, is that if you start giving someone one of these medicines, they know pretty quickly if they're going to tolerate this or not. And so if they make it through that first week, most of them seem to do fairly well. But if they have a really hard time that first week, it's probably unlikely that they're going to want to stay on the medication. So this is our study. This is 1202. Let me see if I can highlight this. So we have stage 1 through 3 hormone receptor positive patients. They have to have an average pain of at least 4 out of 10 on the 0 to 10 scale. And so that's a little bit different from some of the other studies that are going on that have used worst pain. We've actually chosen to use average pain. Now, we want people who have been on the aromatase inhibitor at least for a little while. So you have to have been on it for at least 3 weeks. But then we allowed people up to 36 months. We had originally wanted that to be a much shorter time frame because we wanted people that actually had pain related to the aromatase inhibitor and not just continued worsening of their arthritis or whatever else they have going on in the background. And we just could not accrue. And we had to amend the study. So we are allowing 3 weeks up to 36 months. We're stratifying based on baseline pain score, either moderate or severe, and prior taxane use because we think that's involved. And we're about 2/3 of the way through accrual. We have 195 as of the end of March. 294 is our goal. And I really, really encourage all of you to continue to think about your patients who are on aromatase inhibitors having difficulty putting them on the trial, because we really would like to get this done so we can find out if it helps. One of the big things that we run into with duloxetine, well, with any of the SSRIs, SNRIs, is the huge placebo effect. So even though our pilot data look really good, we do have to compare this in a placebo-controlled manner. As you can see from the yellow part on the bar, that's where people are getting treated. So standard dose of duloxetine is 60 milligrams. But we ramp up the first 2 weeks with just a 30 milligram dose because that really cuts down on the amount of nausea that people have. And then at the 2-week mark, they go up to 60, stay up at 60 until the end, and then gradually taper off, assuming they want to come off the medication. Patients who want to continue on the medication can go on to commercially available duloxetine after the trial. It is generic now, although the price hasn't come down a whole lot. But it is possible. The problem is that we don't have it built in that we can unblind people to see what they were on. So you either have to hope they were on it and then put them on 60, or you have to taper them back up again. I just mentioned how we're giving it. And then the primary endpoint for the trial is change in average pain over that 12-week period. We're also looking at 6 weeks. And we designed, our pilot data was 8 weeks long, but we really designed this so it matched up with the omega-3 fatty acid study, so we can do some cross-trial comparisons. We've included the same questionnaires and things so that we will be able to compare the two trials at least a little bit. The other thing I forgot to mention is we are doing phlebotomy at both baseline and 12 months. At baseline, what we're checking is serum, so we can look at inflammatory mediators and things like that, and whatever else comes along by the time we get all the samples. We also have collected white cells for DNA, and then we're collecting just serum at the 12-week time point. So the key things in terms of eligibility that I get asked a lot is you have to have pain that either started after someone started the aromatase inhibitor or worsened after they started the aromatase inhibitor. We don't want any inflammatory processes. We don't want rheumatoid arthritis or inflammation or arthritis associated with Crohn's disease or something like that. It is fine to have osteoarthritis. This is a postmenopausal patient population. Most people have osteoarthritis, and so that is perfectly fine. People are ineligible if they require antidepressants, and that's because you have to taper off. If you're on an SSRI, SNRI, or some other antidepressant, you have to taper off that in order to go on to the trial. And then when you go on the trial, you either get a placebo or you get the real thing. And so we can't have people who require antidepressants to be on placebo for the 12-week period. But it is fine if you're on something to taper off of it and then go on to the trial if you were on it for hot flashes or for some other reason. It's also ineligible if you're on warfarin or heparin. And the reason for that is because there is a concern for increased risk for bleeding. We have not specifically excluded all the other new drugs, rivaroxaban and all the other ones that are really hard to pronounce. And I'll talk about that in a second. Aspirin is fine. So either baby aspirin or 325 milligrams, that's fine to take. We do have a dose reduction in there per protocol. So if people are on the 60 and are having difficulty, there are ways to decrease it down to the 30. But we are not re-escalating because people just usually don't tolerate it very well. And then in terms of what are these toxicities that I keep referring to, so it's mostly fatigue, nausea, dry mouth, and headache. Those are the main things that people complain about. And so in the study that was reported by Ellen Smith and colleagues with the chemotherapy-associated peripheral neuropathy, it was mostly fatigue, a little bit of insomnia and nausea. They had the same exact treatment plan that we did in their study. And then in our pilot trial, we actually had more reported fatigue. We also had some GI issues, headache and dry mouth. But the main things when you're actually talking to the patients, it's nausea, headache are the biggies. So we have the ramp up to try to reduce the nausea. We have the taper off at the end to try to avoid withdrawal. And then the other thing is the big black box that's on the Cymbalta duloxetine package insert, which is warning about suicidal ideation. And that is why we have the PDQ-9 in there. It has the question about suicide that you have to ask and look at the questions, look at the answer before the patient leaves the clinic. And that is really because of this very rare risk. It really was a risk mostly in children, adolescents, and young adults. That is why, one of the reasons why our age cutoff for the trial is 25. So we didn't have to worry about the higher risk in the younger population. Also, there's not many people under 25 on aromatase inhibitors. But we do want people to have looked at that suicide question. If someone answers yes or maybe, you follow the protocol typical for your site. Getting back to the anticoagulation issue, just to clarify. So all SSRIs and SNRIs actually have a risk of bleeding. It's not very big, but there is an increased risk of bleeding. It's on all the package inserts. And so really what the duloxetine package insert says is patients should be cautioned. It doesn't actually say that you need to exclude people on heparin or warfarin. But since we had done that from the get-go, we just left it. We didn't amend the protocol. But patients should just be aware, even if they're taking Motrin or something, they should be aware that there is an increased risk of bleeding, but that's no different than if someone's on citalopram or venlafaxine. Alcohol use, people should not take these drugs if they are regular users of alcohol and are dependent. A little bit is okay. That's really what the package insert says. And then drug interactions, you're not allowed to be on concomitant SSRIs or SNRIs because of risk for serotonin syndrome. You absolutely cannot be on an MAOI inhibitor. I don't think there's going to be anyone on an MAOI inhibitor that doesn't need an antidepressant, so it's really not an issue. There's also a lot of other drugs out there, like people take some trazodone or some tramadol, and these medicines can cause serotonin syndrome if you use them together. They're not prohibited, but you should be aware and make sure the patients are aware of what to watch out for. So that's really my summary of the trial, why we're doing it, and a little bit about the highlights of the questions I get all the time. And if anyone has any questions, I'd be glad to take it. And also, I just want to encourage everyone to continue to think about this trial when you have patients. People have done a great job so far. We're 2/3 of the way through. We just have a little bit longer to go. And I get a lot of emails from a lot of people with questions, and I'd much rather have you thinking about the trial and clarify things than have you sit out there and wonder and say, oh, I won't bother her, and then not put the patient on the trial. So thank you very much. I appreciate everything.